Welcome everyone to another presentation on bedside ultrasound use in the emergency department. My name is Dave Kirschner, and today we will be covering skin and soft tissue infections using bedside ultrasound. We will cover applications that apply to all patients, and we'll focus on the question, is this an infected area that can be treated with antibiotics, or does it require an incision and drainage? We won't be getting into necrotizing fasciitis or lymph node assessment, but keeping our area of interest located in the skin and subcutaneous tissues. Now, while this seems like a straightforward question, it actually requires us to answer a number of smaller questions. When asking, is there an abscess or not, what we really want to know is, are normal tissue planes maintained? Is there fluid visible in the skin and or subcutaneous tissue? Is there a focal area or collection of fluid within the soft tissue that has the following properties? A swirl or squish sign present? Posterior acoustic enhancement? And is there lack of vascular flow? Now, to perform this, we start in the transverse plane over the area of interest. We slide the probe across the area of interest while staying perpendicular to the skin. If the area of interest is greater than the width of the probe, slide the probe to the side and repeat. You can repeat the scan of the area of interest in the longitudinal plane, taking multiple sweeps to cover the area if necessary. Here are the layers of tissue that are normally seen when interrogating an extremity. The top layer is skin, which includes the epidermis and the dermis. The subcutaneous tissue, also called the hypodermis, is just deep to the dermis. A layer of fascia will separate the subcutaneous tissue from the underlying muscle. The fascia should appear hyperechoic or brighter than the subcutaneous tissue. If it is not, it most likely means that you are not interrogating the fascia perpendicular to its plane. If that's the case, you may need to tilt the probe back and forth until it appears hyperechoic. Underneath the fascia, you will find striated muscle. It can be variable in its depth and can have visible vessels running through it. There may be a group of muscles that is further subdivided, each having its own fascial layer. This again shows the different layers with the muscle both in short and long axis. Briefly, identify the epidermis and dermis, the subcutaneous tissue, the fascia, and the muscle. Can you identify a vessel in the short axis view of the muscle? There it is. Deep to the muscle is a bone. Now, why doesn't the bone have the same hyperechoic appearance with posterior shadowing? The reason for that is because we are not interrogating the bone at 90 degrees or perpendicular to the beam. If we tilted the probe, we could make it appear brighter. Now, our first question was, are normal tissue planes maintained? This one is fairly straightforward in that we are just asking ourselves if it looks like normal tissue. Can we see all those layers that we just talked about? The other component to this is determining if it's the same thickness as normal tissue would be. Now, that might sound like a pain to assess, but unless the area of interest is midline, there will always be a contralateral side to compare to. So, we can more easily answer this question by comparing to the contralateral side. Case in point, this image was taken from a 4-year-old girl who had a dental infection of a right lower tooth. This image was taken with a linear probe over the body of the mandible, with the marker pointing to the right, or posteriorly in this case. This is roughly the line following the bony cortex. As in the previous example, it's not as bright as we might expect because it isn't always perpendicular to the ultrasound beams that are coming down. Now, the tissue superficial, or above the bone, is homogeneous, but it's pretty tough to tell anything more from this image. However, if we compare the right to the left sides, we can see that there is a difference. First, the subcutaneous tissue is thicker on the affected side. Secondly, it is more homogeneous, with some loss of tissue planes. I had measured it out, and the thickness of the subcutaneous tissue on the affected side was 1.4 centimeters, whereas the thickness on the left or unaffected side was 1.1 centimeters. That may not seem like much on paper, but when comparing images side to side, it's apparent enough. The next question is there fluid visible in the skin or subcutaneous tissue? Now really, you will be looking for fluid in the subcutaneous tissue as it surrounds adipose tissue. This is what a cobblestone path looks like, which is often used to describe how adipose tissue looks like when there is fluid surrounding it. In this case, think of the stones as adipose tissue and the mortar in between them as fluid. And this is what it will look like in tissue. First, we identify the skin. Next, we identify the subcutaneous tissue. You can see that there is hypoechoic fluid surrounding the adipose tissue. If you look carefully, you will also see a vessel running through this adipose tissue as it's surrounded by the fluid. Now, where is the skin in this image? In this case, it seems fairly thin. And part of the reason for that is that I've set the depth to 6 centimeters. Now, how about subcutaneous tissue? Here it is. Do you agree that the image is marked edema? We can say that there is fluid in the subcutaneous adipose tissue, but we don't know why it's there. We will need to integrate this information into the clinical scenario to be certain. This is another great example of fluid in the subcutaneous tissues. You can see black or anechoic fluid surrounding adipose tissue. You might even be able to see a blood vessel that bifurcates. Does the fluid extend beyond the fascia to the deeper layers? Here we see the skin. Here we see the subcutaneous tissue. And just below that, we can identify the fascia. Now, while my line is not right over top of it through the entire length of this clip, there is no fluid beneath that line. So now you are scanning through some subcutaneous tissue, minding your own business, when boom, you see it, a hypoechoic, irregularly bordered fluid collection. What should you do? Do you poke it? Do you call surgery? Let it be and give it antibiotics? Well, wait a minute. Are you even sure it is an abscess? So let's say now that we found a focal fluid collection in the subcutaneous tissue and we've measured it to see how big it is. Now what? How do we know that it's an abscess that should be considered for incision and drainage as opposed to some other fluid collection? Well, we're going to go through those 3 questions to sort this out. The first thing that we're going to look for is called a swirl or a squish sign. This is a dynamic visualization of cellular debris moving within a collection of fluid. This will only occur if the collection is not too viscous. Otherwise, it will be difficult to visualize. Like the other ultrasound findings, this one by itself isn't enough to say whether there is an abscess present or not. You could potentially see it in other scenarios, such as a seroma that is organizing, or a hematoma that is in evolution. Again, you put it in clinical context. Are you seeing it on the anterior shin of a patient with a recent scratch to that area? Or in the same location in a patient who has a bleeding disorder? Clinical context is supreme. This is what it looks like. With applied pressure to the area and release of that pressure, visible movement of material within the fluid collection is seen. This one is a little more subtle, but it's still there. This was a young boy with multiple abscesses on his back and buttocks after scratching at what was likely a scabies infection. He had been treated with antibiotics that covered community-acquired MRSA and was improving. I noted this and one other small abscess and informed his family that there was a chance that this lesion and the other might need incision and drainage in the future if the antibiotics didn't lead to complete resolution. Now, how about this one? Well, are we seeing movement within this fluid collection? We are, although it almost looks like something waving or undulating within it. In this case, this is a seroma post-saphenous vein harvesting. The area was not red nor tender, and the patient came in only because there was leaking from between two of the staples. If we were to compare it as well, there doesn't seem to be any fluid in the tissue surrounding it, and it has more linear, smooth borders as opposed to the irregular borders that we commonly see with abscesses. How about this clip? Is there a swirl or squish sign? Again, that question is just asking, is there movement of material within the fluid collection with pressure and release of that pressure? And in this case, there does seem to be some floating in the anechoic fluid collection. This, however, is a clip of a patient with olecranon bursitis. You would think if an abscess was able to get that big, there would be some real debris within it. You will also note, to my shame, that at the beginning of the clip I had lost contact with the skin on the left side of the screen, hence the lack of any visible anatomy. Posterior acoustic enhancement is an artifact that can be seen with some abscesses. If sound travels through a medium or tissue that doesn't absorb or reflect as much sound energy, more of that energy can be transmitted beyond that tissue to the tissue that is found deeper or behind it. In doing so, the tissue behind or deeper can appear brighter than other tissue at that same level. This is often seen when imaging through fluid-filled structures, of which an abscess can be included in that category. Now, this is dependent on what type of material is in the abscess cavity, how old it is, as it could be so thick that there is no posterior acoustic enhancement. Now let's look at an example of it. Looking at this image, we are comparing the echogenicity of the tissue behind the suspected abscess compared to the echogenicity of the tissue at the same depth in other areas. Can you appreciate that the tissue behind this abscess is brighter compared to the tissue at the same level next to it? That is posterior acoustic enhancement. This was an early skin or soft tissue infection in a young child. In this case, do you think there's posterior acoustic enhancement? There doesn't seem to be anything overt in this case, although there could be a little bit beginning. We would still need to check for swirling or a squish sign and also assess for vascular flow. But based on this image alone, there is no reason to poke it yet. In the case of this actual patient, they had been on cephalexin for 2 days without any improvement. I had switched them to clindamycin and they were going to follow up as needed. Now the final question that we are asking is there vascular flow in the area of interest? And this is probably the most important if we are considering actually poking that area. To begin, we need to locate the C or color button to the upper right of the trackball and tap it once. A box will appear on the screen that's outlined in green. To move the box around, simply move the trackball. If you want to change the size of the color box, tap the Set button. By tapping the Set button, you can now use the trackball to change the size of the box both in its height and its width. You will need to tap the Set button again before you can move the color box. I suggest making the color box just a bit bigger than your area of interest. If it's too big, it will take up too much computing power and you might notice that your images aren't as smooth. If you make it too small, you can miss identifying flow in your area of interest. When you have the color button selected, these 4 words will appear on the console. The only one we really need to concern ourselves with at this point is the scale button. We can toggle it up and down to change the velocities that the ultrasound machine will be picking up. Now this will be shown on the left side of the screen when you have color flow selected on the ultrasound machine. And this shows what the scale is. Another way to say this is that the machine is able to appreciate velocities that are going at least this fast, regardless of their direction. Note that it is measured in centimeters per second. So why is it important to adjust the scale as needed? The reason for that is because different tissues will have vascular flow at different velocities. Let's say you were measuring the flow of blood through the heart. It would be overwhelmed at a 15 centimeters per second scale, as the blood going through the heart is moving much faster. On the other hand, you might appreciate no flow over a lymph node if it's still set to 15 centimeters per second. In that case, you would need to toggle the scale down to 3 to 5 centimeters per second. Clear as mud? Perfect. Let's take a look at a few scenarios that incorporate this component of the focused exam. Now, this was a young boy who presented with his father being concerned that there was a reddened area over his left buttock. He had previously had an abscess there that had been drained, but that was a year ago. And he came in wondering if this was another abscess. So now we have the scan in front of us and we're looking at this image. And the first question I have is there posterior acoustic enhancement? Knowing that we're only set to 4 centimeters, we might have dialed back to 6 centimeters so we could see more of the tissue behind this area of interest. That being said, it does seem to have some posterior acoustic enhancement. This just means that the tissue that it's going through to get behind it is allowing more energy or sound waves to get through to that tissue behind the area of interest. Also, you might note to the right side of the screen that the tissue surrounding the area of interest seems to have fluid within it, giving the typical cobblestone appearance. Now, is this enough to say that it's safe to poke? No, you guys are smart. Next, we check to see if there is any swirling or squishing when compressed. In this case, it's difficult to tell, but there doesn't seem to be any swirling. Now, this could just mean that it's old and it's been solidifying, or it could be that it's not an abscess. In this case, the next step, as always, is to put on color flow. And this is what we see when color is added. There is clearly organized blood flow within this tissue, directing us away from the diagnosis of an abscess. In this patient, he had an abscess to that buttock a year ago, which had healed by secondary intention. This is what his granulation tissue looks like. He came in, again, because his dad thought it had been weeping a little bit more. But again, it didn't look red and it wasn't tender. And when we got the consultative ultrasound, it showed this, a large irregular area of granulation tissue, but no abscess identified. Now, as a bonus question, what should I have done if there was no flow visible in the color box that I had? I could have either moved it around to assess all parts of the area in question. I could have made the box a little bit bigger, and to be sure, maybe I would have dialed down or toggled down the velocities that I was interrogating. Again, all of this is to be safer with the patient before we put a needle or a scalpel in needlessly. How about this area? Do you think it's an abscess? So again, we have what appears to be an anechoic or maybe even a hypoechoic fluid collection within the subcutaneous tissues. It has irregular borders. Does it have posterior acoustic enhancement? It seems to. If we look at the video on the upper left side and we look at the far left and the far right, it appears as though that area is darker than the area right behind the abscess or the potential abscess. Does it have a swirl sign? Yes, it does. With compression and release, we can see echogenic material within that fluid collection moving about. And does it have vascular flow? In this case, yes, it does. Well, what do we do with that? Everything else was saying it was an abscess. In this case, while it does have flow, it only appears to be flow on the periphery of the abscess. It doesn't have flow going straight through it. Now, to be certain, again I would show you how I slid the color box all around the area of interest, or I could have made it bigger to encompass the entire area. At the least, I should have put the color flow over the area I would have poked, which I indeed did, and it was an abscess. Now, with all that in mind, thinking of tissue planes, thinking of fluid within the subcutaneous tissue, and thinking of those three questions we ask when we see a definite collection of fluid in terms of posterior acoustic enhancement, swirl sign, and vascular flow, let's look at a couple more cases before we end. Case 1. A patient comes in with erythema over the posterior aspect of their thigh after a bug bite 3 days ago, which they scratched. You can see where the central scratch mark was, and it is surrounded by an erythematous and tender area that is warm to touch. Do you think there is an abscess there that needs to be drained? Well, I hope you said no, and here's why. Again, are normal tissue planes maintained? From what we can see, we have skin superficially, and we have subcutaneous adipose tissue underneath. If we follow up with the second question, is there fluid within that subcutaneous tissue? The answer is yes, which would suggest that there's at least some capillary leak, and this would fit with the cellulitis. Now the next question is there a focal fluid collection with irregular borders? And the answer to that is no. And so since there isn't a pocket of fluid, we don't need to assess those other questions in terms of posterior acoustic enhancement, swirl, or vascular flow, because there's no abscess. How about this area in a young man with a painful and reddened area to his right axilla? So there appears to be a fluid collection with irregular borders. Is there posterior acoustic enhancement? Yes, there is. The area behind this fluid collection in the video appears brighter. Now, we don't have a swirl sign in this clip, but there does seem to be echogenic debris within it. In addition to that, if we look at the still image on the right, that is just a still image of a clip that I had taken which showed that there was no vascular flow within it. I had moved the box around entirely, and I had also taken down the scale further, and there was no flow. The main thing is knowing that there's no flow, it is safe to poke this. And indeed, in his case, it was an abscess. Again, if we put this in clinical context, our clinical likelihood was already quite high in this case, even though we didn't have the swirl sign, or at least not shown in the images that I have for you. How about this one? Do you think there's an abscess? Yes or no? It doesn't have as much fluid in the subcutaneous tissue as some of the other clips that we have seen. And it also doesn't have a focal fluid collection, so we can move on. No focal abscess, but still concerning for cellulitis in the correct clinical setting, in which case we'd consider our options for antibiotics. And last one, what do you think? This is again a fairly young man who is a little overweight who comes in with swelling to the inner aspect of one buttock. It is tender, warm to touch, but you can't appreciate any fluctuance on your physical exam. Based on this clip alone, do you think this is an abscess? I hope you said absolutely there's an abscess, but let's go through it nonetheless, thinking of those three questions that we ask when we find a focal collection within the soft tissue. There appears to be hypoechoic fluid, again with the irregular borders, and there also appears to be internal debris that swirls when pressure is applied. In addition to that, there are areas about right in the middle of the screen, at least halfway down, that appear to be showing posterior acoustic enhancement. Should we poke it? Now this is a trickier one. So even if there is no flow which there wasn't in this case, we likely shouldn't poke this one. And the reason for that, I would suggest, is that if you can't see the posterior wall of an abscess, or it's near vital structures, i.e. a sphincter, do not poke it, but wait for surgical consultation prior to incision and drainage. In this young man's case, he was taken to the operating room for proper management of this ischiorectal abscess. So that is it in a nutshell about assessing skin and soft tissue, assessing for fluid within the tissue to fit that into our clinical picture to determine if we think this is a cellulitis, and then also to assess if there's an abscess or not that we think needs incision and drainage. Again, do we have normal tissue planes? Is there fluid visible in the skin and subcutaneous tissue? Knowing that those two questions are really answering the question about a cellulitis or not. And then if there is a focal collection within the soft tissue, that most likely will have irregular borders. Does it have posterior acoustic enhancement, lack of vascular flow, and a swirl or squish sign? Not every abscess that we see will have read the textbooks to have all of these signs. But again, you'll have this discussion with the patient, maybe their family members, maybe a surgical team, likely a consultative ultrasound potentially as well, and you'll go from there to make an informed decision. So there you have it, a brief overview of assessing the skin for the presence of abscesses or cellulitis. Please consider all of these questions before poking. I hope you found this useful. Take care and happy scanning.